In this section, we will talk about the lining epithelium. Well, we are doing the histology in two parts. In this, we are just talking about the lining epithelium of all the important system. And what I've seen is that usually people, when they learn the lining epithelium, they just make a table or they make a flow chart for the lining epithelium and just keep mugging them up. In fact, it is important to understand that what is the basics behind the different type of epithelium, the structures and the functions of those epithelium, and then based on that knowledge, we can understand that what kind of epithelium is apt in those certain places. So we will first talk about the types of epithelium, the classification of the epithelium, and then we will discuss it all system wise. So let's get started. So first, before we start with the epithelium, we need to know the difference between the epithelium and epithelioid. Now, when you say epithelium, obviously it is the cell layer which is covering the outer body surface, or it is covering the internal organ, or it may be forming a part of the gland also. You can see it in the thyroid gland, we have a lining, or any other gland. So lining of any structure, whether it is outside or inside, that is what we call as epithelium. Now, how epithelium is different from this epithelioid? Now, when you say epithelioid, I'm sure you must have heard of this epithelioid in pathology also. But that epithelioid is the aggregation of that macrophage in response to some particular cell injury or certain kind of tumors. So that's a different epithelioid. In normal histology, the epithelioid actually means those cells which have the appositional surface, which have the basement membrane is also present, like the epithelium, but they do not have free surface. If a cell surface is not present, if we don't have a free cell surface, then that cluster of cell is called as epithelioid. So epithelium and epithelioid, the main difference is that epithelioid, they do not have a free cell surface. The cells from where the epithelioids are derived from, that is immature cells, they may have a free surface, but when they mature and they become epithelioid, they do not have the free surface. Now, there are some good examples for the epithelioid, and it's again a potential question to be asked in the exam, and they've already asked this question once. Now, the examples of the epithelioid are, now one is the interstitial cells of the Leydig in testis, the lutein cells in the ovary, the islet of Langerhans. All these are the epithelioids. We do not have the free surface for these cells. Also, anterior pituitary and adrenal gland parenchyma. Along with that, even sebaceous gland, also reticuloepithelial, or also called as epithelio-reticular cells of the thymus, or you can say the ER cells of the thymus. So these are the examples. These are very, very important example, and you should remember all of them. The intestinal cells of the Leydig, lutein cells, Langerhans, adrenal gland, parenchyma, the anterior lobe of the pituitary, the ER cells of the thymus, and the sebaceous gland. Now, just a small mnemonic which may help you to remember these, like the seal and just 1, 2, 3. When you say seal, I've written 1, 2, and 3 below E, A, and L. The S here will remind you of sebaceous gland. S is for the sebaceous gland. We said E, and 1 is written below it. So 1 is with the E, alphabet E. What is that? That is epithelio-reticular cells. A and 2 is written below A. So we have 2 with the A. 1 is the adrenal gland, and we have anterior lobe of the pituitary. And L3, below L it is 3. We have 3L over there. Leydig, lutein, Langerhans. So these are the examples of the epithelioids, and very limited example we have, and it's not difficult to remember them. Now, coming to the classification of the epithelium, after understanding the difference between the epithelium and epithelioid, epithelium is classified based on the two main factors, and those two factors are the number of cell layers and also the shape of the cell, the number of the cell layer and the shape of the cell. Like based on the shape of the cell, we have squamous and cuboidal and columnar cells, and based on the layers, we say stratified, pseudostratified, all that. So we have two types of epithelium based on these two factors. One is a simple epithelium, and then we also have the stratified epithelium is also there. Now, in the simple epithelium, as we all know, we have these main three types, the squamous, the cuboidal, and columnar. The squamous cells obviously are the one which are having the basement membrane, and you see the flattened cell with the round or the flat nuclei. So they are basically present at those places where the exchange has to take place between the two different environments. Cuboidal cells, on the other hand, their length and width are more or less the same, and the nuclei is present in the center. The round and central nucleus is there in that case. So we have more or less all the walls are of equal size, and we have a central round nucleus in the cuboidal cell, the typical cuboidal cells. Columnar cells, on the other hand, their length and width are not proportionate. You obviously have the more length than the width. They are called as columnar. And please note that the nuclei are oval, they are basal, but they're not touching the basement membrane. So please understand that they're present basally in the cell, but they're not touching the basement membrane. That kind of nuclei we see in a typical columnar epithelium. So that's a simple cuboidal and the columnar type of epithelium. Now from the simple epithelium, let's move on to the stratified epithelium. Well, as the name suggests, the stratified, there are stratification, the layers are present there. And the nomenclature of the stratified epithelium, it is based on the topmost layer. Now, no matter what kind of cells are present in the bottom or in between, but you need to look at what is the top layer over there. So it's a top layer which decides the name of the epithelium. Like, look at this example here. Now you're looking at this one very nice slide is there, and you can see all these cells beautifully arranged. And we have all kind of polyhedral cells in the middle. But by the time you reach the top, now you see that we have the squamous cells present over there, and that's why we call it the stratified squamous epithelium. The top layer is squamous, so we call it stratified squamous epithelium. Now this one is non-keratinized. We also have a stratified squamous keratinized epithelium. We'll discuss that separately in the integumentary system. So I want you to try for these two examples. Now look at these two guys. And could you tell me that what kind of stratified epitheliums are these? Now once again you need to look at the top layer. Now the top layer here, in the one above, you can see the top layer is made up of cuboidal cells. So obviously that is called as what? Stratified cuboidal. No matter the basal cell is cuboidal, you may have columnar in case of some ducts, we'll see that. Whereas look at this example here, in which the basal layer looks like cuboidal, then we have some polyhedral cells in between, but by the time we reach the top, it's columnar. So we call it stratified columnar type of epithelium. They usually are present in the duct system, the stratified cuboidal and stratified columnar. So that's how we name the stratified epithelium based on the top layer. After stratified epithelium, let's now talk about a special category in the epithelium, and those two special category are, number one, we have epithelium called as pseudo-stratified ciliated or non-ciliated columnar epithelium. Now when you say pseudo-stratified columnar, that means the true stratification is not there. We do not have a multiple layer of the cell, but they look like that we have a multiple layer. All the cells are resting on the basement membrane. Now you can see all the cells are resting on the basement membrane, but because some cells are squeezed in between and some are reaching the top, so the nuclear level is different. Now see another example in the real-time section. Now you can see the nuclear level is different in all that image. We can see some goblet cells also, just ignore that for a while. But these variant level of the nucleus is the one based on which we call them the pseudo-stratified columnar epithelium. They are actually a simple epithelium, but because they look like having a layer, so we call it pseudo-stratified columnar epithelium. Another special category in this is the transitional epithelium, or also called as a urothelium. Very important, the urothelium, we will discuss them in the lower urinary tract. Now urothelium or transitional epithelium is again having multiple layers, maybe starting with the basal layer of the cuboidal cells, and then we have some polygonal cells in between. But again, when you reach the top, look at the topmost layer, guys. The topmost layer is made up of the kind of cells which are umbrella shaped, dome shaped. That's why we call them umbrella, because it is covering more than 2 cells, or more than 2 to 3 cells they are covering it underneath them. So we call them umbrella shaped cells which are on the top. And that's why we call them, that is called as the urothelium or the transitional epithelium. The special characteristic of the transitional epithelium, we'll talk about them separately in the urinary structures histology. The problem here is, it is not difficult to differentiate the urothelium from the other stratified squamous or other stratified epithelium, but when it is in the relaxed state. Now let's look at these two examples. You're looking at the urothelium only, but in the picture above, you're looking at the urothelium which is relaxed. So the top layer, which is the dome shape, we have these caps which are formed over them. They will help you to identify it is a urothelium only. The only problem comes when you are looking at the picture of a stretched urothelium. So when you look at the stretched urothelium, the upper layer, look at this, it looks flat. It looks like squamous only. So you got to be a bit careful about differentiating between the stratified squamous and the stretched urothelium, because they look more or less the same. Although probably it won't be a difficulty, because when you look at the stratified squamous epithelium, the number of the polyhedral cells in between, I mean between the basal layer and the top layer, are way more than the transitional epithelium here. So that could be one way to identify that. But when you look at the stretched urothelium, it can create a confusion sometime that whether it is uro or is it a stratified squamous epithelium. So next we will talk about the endothelium and the mesothelium. While talking about the epithelium, we all heard of these two terms as well, the endothelium and the meso. The endothelium is obviously the lining epithelium which is present inside the blood vessels or inside the lymphatic vessels. That is the term used for the endothelium here. But when you say the word mesothelium, the mesothelium is the squamous layer which you will see covering all those closed cavities, like the peritoneal cavity or the pleural cavity. So that epithelium is called as is given a special name, and that is called as a mesothelium. Now, be it endothelium or mesothelium, they are all the simple squamous epithelium only. The question here is, mesothelium and endothelium are simple squamous. Now, one exception is there, and that exception is seen in some lymphatic tissue where their post-capillary venules, they are having the cuboidal cells, and we call them high endothelial venules. So in case of some post-capillary venules of certain lymphatic tissues, like in case of spleen only, so you have these high endothelial venules which are not squamous, they are cuboidal in shape, which are cuboidal in shape. You can see in this image here. Now, you're looking at a section of, through that, it's a magnified picture of a venule. And what you see there, that the cells which are lining the wall of the venule, they are not squamous, they are cuboidal. And how you identified they are cuboidal? By looking at the round nucleus. So they have a round central nucleus rather than having a flattened nuclei, which is a typical feature of any venule anywhere, except in case of the post-capillary venules in certain lymphatics, which are cuboidal. So that again can be a question, that in which kind of endothelium the lining epithelium is not squamous, and that is high endothelial venules. So this is some basics about the kind of epithelium, the simple and the stratified one, and how the cells will look like, how their nuclei are present, and some basic features to differentiate them. So now let's apply them and try to understand the lining epithelium of the three major systems. We'll start with the GIT, then respiratory, and then we'll also talk about the urinary system as well. So let us start with the GIT first. So we'll be discussing the lining epithelium of the GI tract in three parts. So in the part one, let us first start with the oral mucosa. Now, oral mucosa is basically of three types. In the three types, we have a masticatory mucosa, then we have a lining mucosa, and then we also have the specialized mucosa, which is obviously about the specialized epithelium of the tongue. Now, when you say this masticatory mucosa, we are talking about the mucosa of the gingiva and also of the hard palate. The gingiva and the hard palate, and the type of epithelium present over there is stratified squamous keratinized epithelium. It is a keratinized stratified squamous. It is keratinized or parakeratinized type of epithelium. Now, please understand one thing. Anything in the oral cavity, be it gingiva, hard or soft palate, the tongue, tonsil, whatever it is, the epithelium has to be stratified squamous, because this area is subjected to a lot of friction. And wherever we have more friction, be it the oral cavity or the vestibule of the nasal cavity, the vocal cord, the terminal anal canal, the terminal the urethra, you have stratified squamous epithelium. But we still need to know that what kind of stratified squamous. Is it keratinized or non-keratinized? So in the masticatory mucosa, we have this keratinized stratified squamous. But when you talk about the lining mucosa, lips, cheek, soft palate, inferior surface of tongue, all these lining mucosa inside the oral cavity, that is having the stratified squamous but non-keratinized. It's a non-keratinized stratified squamous epithelium. Except one exception is there in the lining mucosa, and that is the vermilion border of the lip. If you look at this vermilion border of the lip, this is having the, again, stratified squamous only, but that is keratinized stratified squamous epithelium. So remember that exception in the lining mucosa. And when you say specialized mucosa, obviously we are talking about the dorsum of the tongue. The dorsum of the tongue is having, again, stratified squamous epithelium, and it's non-keratinized stratified squamous epithelium, with again an exception there, and that exception is filiform papillae. In case of filiform papillae, the epithelium is keratinized here. So this is about the oral mucosa, the masticatory, the lining mucosa, and the specialized mucosa. All of them are having stratified squamous epithelium, but you got to remember that what are the exceptions there, where we have keratinized and where it is non-keratinized. So let's talk about the teeth. The teeth we can broadly divide into 3 layers of the teeth: the enamel, the dentine, and the cementum. And because we're talking about the lining epithelium, so let us focus only on the enamel part. Now, as you can see in this picture, the enamel, the reason I want to tell you about the enamel is in the lining epithelium, because unlike bone, which are derived from the connective tissue, the enamel is actually derived from the mineralization of the epithelium only. The amyloblasts, which are columnar cells, they will undergo a process called as amylogenesis, and that will give rise to the enamel. So development wise, it is derived from the epithelium only. The enamel is derived from the lining epithelium only, which are columnar kind of lining epithelium. And as we know, this enamel is like 96 to 98%, it is made up of the calcium hydroxyapatite, and which is the hardest substance, the enamel being the hardest substance in the human body. Talking about the second part of the GIT tract lining epithelium, let us talk about the salivary gland. The 2 types of acinus that we see in the salivary gland, that is the mucous acinus and the serous acinus. Now, mucous acinus, if you look at the picture of mucous acinus, these are the columnar cells, and they have a flat and basal nuclei. As you can see in the picture, we have a flat and the basal nuclei, and then you can see lots of mucogen granules which are present in it. And when you stain them, because they have a lot of mucopolysaccharides present inside, so they do not stain well with the common dyes. So it looks like they have a clear cytoplasm when you see it in the histological section of H&E. As you can see in this image, if you look at one of the acinus here, this is a mucous acinus. Look at all these flat and basal nuclei present, and you can see the clear cytoplasm because the dye is not able to stain the mucopolysaccharides there. Whereas in case of the serous acinus, the cells are more or less triangular or pyramidal in shape. They also have a nuclei which is relatively basal in position, but that is a rounded nucleus. Unlike the mucous acinus, we have a rounded basal nucleus present in case of the serous acinus, and they stain intensely in the H&E staining, so they look very darkly stained with all these granules present in the apical region of the cell. So look at this one, the section in which you can see 2 or 3 the serous acinus here. Look at all these nuclei, we have a rounded nuclei there, and then look at all these granules which are present in the apical region of the cell. And unlike the mucous acinus, the cytoplasm doesn't look clean or clear in this case. Now moving on to the salivary gland ducts. Now the ducts in the salivary gland can be we can have an intercalated duct, we can have the striated duct, and we can also have the excretory duct. So the 3 kind of ducts that you will notice: the intercalated, the striated, and the excretory duct. Intercalated ducts are those which starts from the acinus, the serous or mucous acinus, whatever is that begins from that acinus. That duct is the intercalated duct. Now in this picture which you are looking at the inset, you can see a very small part of the serous cell over there as well, and the rest is a duct, which is an indicative of it is starting from the acinus. And the kind of epithelium that you see in these ducts is a single layer of a simple cuboidal epithelium. A single layer of simple cuboidal epithelium will be seen in case of intercalated duct. The important one here is the striated duct. Well, as the name suggests, striated, that is because of the striations. Epithelium could be cuboidal to columnar. It could be a simple cuboidal to columnar epithelium. But the feature is, if you look at this in this picture, is the basal striations. The infolding of the basal plasma membrane will form these striations, on which you can see this arrow running here, that is the basal striations, which will push the nucleus more toward the central part. Unlike in the acinus, where the nucleus is more toward the base, in the striated duct, the nucleus is pushed more toward the central part because of all these basal infoldings of the plasma membrane. And between these infoldings, we have the mitochondria arranged longitudinally. And this arrangement of basal infolding and the mitochondria is an indication of the function which is performed by the striated duct, that is a reabsorption of the fluid and the electrolytes. So that's the feature of a striated duct. Intercalated duct, simple cuboidal. Striated duct, cuboidal or columnar usually, and that is having a striations in the base. And then comes the excretory duct. The excretory duct, the large excretory duct like the parotid duct or Stenson's duct or Wharton's duct. In that we have a stratified epithelium, that is stratified cuboidal or stratified columnar. The smaller duct usually have stratified cuboidal epithelium. The larger duct, excretory duct, will have a stratified columnar. In this case, it is a case of a stratified columnar epithelium. And as we said, how will you identify the stratified epithelium? By looking at the top layer. Now this top layer here is a columnar cell. Look at all these elongated cells with basal oval nucleus. So that's a stratified columnar epithelium, which is usually seen in the larger ducts, parotid, Stenson's, all these ducts. Now let's talk about the GIT wall. Now histologically, we can divide the wall of the gastrointestinal tract in 4 parts. That is the mucosa, the submucosa, the muscularis externa, and the serosa. And as we know, the mucosa can further be divided in 3 parts. Mucosa is having the 3 layers. One is the lining epithelium. We have the lamina propria, and we also have the muscularis mucosa. And because our topic is the lining epithelium, so let us focus on the lining epithelium of the GIT wall, starting from the esophagus all the way till the anal canal. So let us start with the esophagus first. So in the esophagus, the lining epithelium is again stratified. Now continuing with the lining epithelium of the pharynx, we have a stratified squamous epithelium in case of the esophagus as well. Now obviously it is non-keratinized stratified squamous epithelium in case of human. The surface cells, they may have a keratohyalin granules, but still there is no keratinization. Now in human, it is non-keratinized. In certain lower animals, or you can say in some quadrupeds, you will see the keratinized stratified squamous epithelium based on their dietary activity. So in human, it is non-keratinized stratified squamous epithelium. And when we move on to the stomach, the lining epithelium in the stomach will be the simple columnar epithelium. See, as I said, we need to understand the lining epithelium based on the function. When we are talking about the pharynx and the esophagus, it is just the conducting zone only. It is no absorption, no digestion is taking place in that region. But by the time the food reached into the stomach, the secretory enzymes have to come into the picture. In the intestine, the absorption will take place. And then the motility should be more in case of large intestine. And by the time we reach the anal canal, again, we are subjected to a lot of friction there. So that's how the lining epithelium will keep on changing based on the requirement. So in the stomach, we said that in the lining epithelium in the stomach is a simple columnar epithelium. These are secretory cells, the simple columnar. You can see the basal oval nuclei there. And the type of mucus they secrete which lines the surface inside. So we call them surface mucus cells, which is rich in the potassium content and the bicarbonate also. And that actually protects the lining epithelium from the acidic content of the stomach as well. So that's the lining epithelium of the esophagus, that is non-keratinized stratified squamous. And in case of stomach, it is the simple columnar epithelium, which is secreting all this surface mucus here. Well, in the small intestine, see, what is the main requirement in the small intestine? Because of the digestive purpose, the amplification of the mucosa is very much needed in the small intestine. And that amplification or that increment in the surface is done by the 3 major modifications that you will see by the mucosa as well as submucosa. And one of them is the presence of the valve of Kerckering, that is also called as the plica circularis. Then we have the villi, which is again a big factor for increasing the surface of the small intestine. But the main factor, the main amplification is not by the plica or by the villi, it is by the apical surface of the cell bearing microvilli. So if let's say the question is asked that the amplification of the major amplification of the small intestine surface is done by what? Is it the valve of Kerckering? Is it the villi or microvilli? So answer is the microvilli. That's the main thing. And these microvilli, they will give the appearance to the tall columnar cells or the enterocyte cells of the small intestine like a striations again. So that's why we also call it the columnar cells with the striated border. So the striated border of the columnar cell, that is because of the presence of microvilli in them. The 5 types of cells which are present in the small intestine are, Now, one is obviously the enterocytes, which we said having the striated border. These are the tall columnar cells, the predominant cell, and they are covered with the secretion that is glycocalyx. Well, glycocalyx is a glycoprotein, and this glycoprotein will help in the absorption of certain kind of amino acids and the sugar. That is what the glycocalyx is. Another type of cell that you will see in the small intestine is the goblet cell, the mucus secreting, the unicellular gland also we call them, that is the goblet cells. We do have Paneth cells. We'll talk more about the Paneth cells in the next section. We also have the cells that is called as enteroendocrine cells, which are found in most of the lining of the GIT. And we also have the M cells, also called as the microfold cells. And these microfold cells are present in that region where the lamina propria is holding some lymphatic nodule inside. Now, just to correlate with some other question, they asked this question that the gut-associated lymphoid tissue. Now, whether it is gut-associated or it is the respiratory-associated lymphoid tissue, whatever it is, they are all present in the lamina propria only. And in the region where it is present, that epithelium over there, that epithelium is by the cell which is called as the M cells or the microfold cells. So these are the main 5 types of cell which are present in the lining epithelium of the small intestine. Now again, a small mnemonic which may help you to remember them, that is PGMEE. Well, I'm sure that no one will forget this mnemonic, at least the postgraduate medical entrance examination. The P here will remind you of the Paneth cells, G for the goblet cells, M for the microfold cells, and the 2 E over there, one is the enteroendocrine gland and also the enterocytes. So the 5 types of cell in the lining epithelium of small intestine. So here's the schematic diagram which is showing the types of cell present in the small intestine. Now, one we said is a goblet cell. Now look at this picture and you can see this goblet cell here. It's a beautiful picture of a goblet cell where you can see the typical goblet shape with the basal elongated nuclei, and then we have this mucus filled region which is usually empty because it is washed off or it is gone in case of when we're doing the dehydration and the fixation of the slide. So that's the goblet cell. You can see loads of goblet cells present there. Like one example is this is also a goblet cell. And the second type of cell which we again can notice here are these tall columnar cells, that is the enterocytes, the tall columnar cells, and you can also appreciate their striated border. Can you see that? Those striations, that is a microvilli present on the surface. So the striated border of the tall columnar enterocyte. The goblet cells and the enterocyte here. Another important cell present in the lining epithelium of the small intestine are the Paneth cells. Now these Paneth cells are present in the base of the intestinal gland, or you can say in the valve of Kerckering. Now these cells are usually pyramidal in shape. As you can see, they are the pyramidal in shape. You can see that in the picture, in the schematic picture there, which is having a basal nucleus which is usually flattened or oval. And they have all these acidophilic granules which are present in them, which gives them a typical appearance because they stain intensely with the eosin. So acidophilic granules are present near the apex, as we said, and we have the oval and the basal nucleus. Now look at this picture here, and they are very, very easily identified, and you can separate them from other cells which are present in the intestinal glands. So you can see this nucleus, that is the nucleus which are basal here, and look at all these acidophilic granules which are present in the apical region. And these granules, these acidophilic granules, these cells are basically rich in the zinc content and also in the antibacterial enzymes like lysozymes. So they are the cells which are actually maintaining the immunity of the lining of the small intestine. So antibacterial enzymes, lysozymes, and the rich in zinc content. And this was the question even asked in the exam regarding the Paneth cell, that which of the following is a feature for the Paneth cell, that they are rich in the zinc content, and that is true. Now moving on to the large intestine, including the appendix. If you look at this, the picture, the histological section of the large intestine, the lining epithelium, how it is different from the small intestine is by the absence of the plica, the circularis, and also the absence of the villi. But what they have, which is also present in the small intestine, is the crypt of Libercoon. The crypt of Libercoon is a feature of the small intestine, and so is the feature of the large intestine as well. So basically the lining epithelium of the large intestine is just like the small intestine only, with the 2 major differences that you should remember. Number 1, absence of Paneth cells. The Paneth cells we just discussed, they are not present in case of the large intestine. And the second difference, which is quite notable from this picture only, you can see the enormous increase in the number of goblet cells. Goblet cell, we started seeing the goblet cell in the duodenum, but there are few goblet cells in the duodenum. The more you go down into the small to the large intestine, the number of goblet cells will keep on increasing. The duodenum is having goblet cell, more are present in the jejunum, then the ileum, and by the time you reach the colon, the large intestine, it looks like that we only have the goblet cells. We do have the enterocytes as well here, but it looks like that it is completely flooded with the goblet cells only. The function has changed now. The function has changed. Now we need to move the feces through the colon, and that's why we have loads of these mucus secreting goblet cells present in the distal part of the colon. Now talking about the lining epithelium of the anal canal, now we can divide the anal canal into 3 zones, as you can see there. One is the colorectal zone, which is present above the pectinate line. Then in the region of the pectinate line, this is called as the ATZ, that is anal transition zone. That is the ATZ, that is anal transition zone. And the portion below that is called as a squamous zone. So we have a 3-part, we can divide the anal canal for the histological basis in 3 parts. That is the colorectal, ATZ and the squamous zone. The colorectal zone is having the lining epithelium, which is just like the lining epithelium of the colon above. So it is the simple columnar epithelium with loads of goblet cells present there. But if the question is asked on the anal transition zone, the transition zone is having the epithelium, which is now not the columnar, it becomes the stratified columnar epithelium. So you can see the change now taking place when we go toward the perianal region. It was simple columnar. Now the layer have increased, it becomes stratified columnar, which is in the pectinate line region, or you can say in the ATZ region. And if you go below, that is in the squamous zone, as the name suggests, squamous zone, because we have a stratified squamous epithelium there, which is just like the epithelium of the perianal skin. Now, I couldn't resist showing this one wonderful picture that I have here. Now, look at this picture, guys. This is a picture which is showing all the 3 zones. Now, on my extreme right, you can see this lining epithelium is the usual epithelium of the large intestine, which is a columnar epithelium, and you can see all these goblet cells which are invading in. This here is the ATZ, the anal transition zone. Now, look at this anal transition zone. The columnar epithelium is now converting into the stratified columnar. Now, look at the top layer. That's how we identify the stratified. If you look at the top layer, they are not the flattened cells. They are the cells with the oval nuclei. And that's why it is stratified columnar epithelium in that zone, the pectinate line region. And you go more distal, which is then continuing with the perianal skin. This is a squamous zone because we have a stratified squamous epithelium. The surface cells here are having a squamous cells. So that's a picture which is showing you the junction of the colorectal region, the pectineal line, and then we have the squamous region. Here, this epithelium is stratified squamous, non-keratinized. We go more further, we go out, it becomes the keratinized stratified squamous epithelium. So that is about the lining epithelium of the gut. So let us have a quick summary of what we discussed in the lining epithelium of the GIT. We said the gingiva and the hard palate, that is the part of the masticatory mucosa, was having the stratified squamous epithelium, but that was keratinized. Then the lip, the cheek, the lower part of the tongue, soft palate, all this was again having stratified squamous epithelium, but that was non-keratinized. Dorsum of the tongue, the special epithelium, the dorsum of the tongue is also non-keratinized stratified squamous epithelium. I hope you remember those 2 exceptions. One was of the filiform papillae in the tongue and also the vermilion border of the lip, which is having the keratinized stratified squamous epithelium. Coming on to the duct part, intercalated duct was having a simple cuboidal epithelium, the single layer of simple cuboidal epithelium. Striated ducts, if you remember those basal striations which are pushing the nucleus in the center, those were having the cuboidal to columnar epithelium, but with the basal striations. The excretory duct, the large duct, the excretory duct was having the stratified cuboidal to the stratified columnar epithelium. If we have a small excretory duct, that will be usually the stratified cuboidal. The large excretory duct like the Stenson's or the Wharton's duct, they have a stratified columnar epithelium. Then the esophagus again the stratified squamous epithelium. Stomach, the simple columnar epithelium with the cell which is having the glycocalyx on the surface, that is. The small intestine Stomach, again having a simple columnar epithelium. Small intestine is also having a columnar epithelium but with a striated bottom, right? And so is the same epithelium we have in the large intestine as well. But as we said, the number of goblet cell will keep on increasing as we go from the small toward the large intestine. And then we have the three zones which we just discussed. The colorectal zone, which is again having the same epithelium of the tall columnar cells, or just like the large intestine. The ATZ, which is having a stratified columnar epithelium. And finally, the squamous zone, which is going and meeting with the perianal skin, that is having stratified squamous epithelium. We started with stratified squamous in the beginning and we end with the stratified squamous epithelium at the end. So guys, before talking about the type of lining epithelium present in the respiratory tract, let us talk about the types of the cells which are present, the different type of cells which are present in the lining epithelium of the respiratory system. So we have mainly these 6 types of cell which are present in the lining epithelium. Now starting with, we have the main cell, that is ciliated cell, which is like pseudo-stratified ciliated columnar, or simply ciliated columnar, or maybe ciliated cuboidal cells at places. So ciliated cells. We'll talk about them separately. Then we have the goblet cells, obviously the mucus secreting cells, the goblet cells are also seen. The third type of cell that we'll see in the lining is the brush cells. Now, as you can see in the schematic picture also, the one which are shown with the blue, the brush cells, they do not have the cilia, but they have a blunt microvilli present over them, and that's why we call them the brush cells. Then we have these important cells called as the granule cells, also called as the Kulchitsky cells. That question is also asked once, the Kulchitsky cell or the granule cells. And these are the endocrine cells which are a part of a diffused neuroendocrine network. We will talk about the diffuse neuroendocrine system when we'll talk about the histology of the endocrine glands. So just remember, we got the endocrine cells there, which are called as the Kulchitsky cell or the granule cell simply. Another type of cell that we have in the respiratory epithelium, that is the basal cell. Now again, you can appreciate from that picture the basal cells which are kind of squeezed at the base and they are not reaching the apex. And these basal cells are actually the stem cells which will give rise to all other kind of cells. Whatever other kind of epithelial cells we have in this lining epithelium, they're all derived from the basal cells. So they are the stem cells. And lastly, the cells which will appreciate from the terminal bronchioles and onward, they are called as the Clara cells, which secrete the surfactants and will keep the lower respiratory tract patent, will not allow it to collapse. That is the Clara cells. We'll discuss all these cells separately also when we'll see the different kind of lining. So again, a mnemonic here to remember all these type of cell. The 2B, the 2G, 2C, 222. So 2 boy, 2 girls, 2 children. That's how you can remember 2 boy, 2 girl, 2 children. What are the 2 boys here? The boys are the basal cells and the brush cells. 2G, the 2 girls, that is with goblet cells and the granule cells. And the 2C, the 2 children, the 2C are the Clara cells and the ciliated cells. So these are the mainly 6 type of cells present in the lining of the respiratory system, the 2B, 2G and the 2C type of cells. So let us talk about the lining epithelium in the different part of this respiratory tract. Now guys, the nasal mucosa, all the paranasal sinuses and the larynx, even the trachea, you can see the main bronchus, that is the one which supplies the right and the left lung. And then we have all these lower bronchus going into the different lobes of the lung. Segmental bronchus, which are supplying the bronchopulmonary segment, that's how they're divided. And also the proximal part of the bronchiole, not the entire bronchiole, the proximal part of the bronchiole. All these, starting from the nasal mucosa, I said, they're all having the typical respiratory epithelium, and that is pseudo-stratified ciliated columnar epithelium. Look at this beautiful picture of the pseudo-stratified ciliated columnar epithelium, where you have all these different level of the nuclei present, which is giving a appearance of the false stratification. Obviously, cilia can also be appreciated. So as I said, I repeat again, this barring this vestibule part of the nasal cavity, which is having the stratified squamous. Then beyond that, the nasal cavity, the paranasal sinuses, the larynx, the trachea, bronchus, large bronchus, and the proximal bronchiole, they're all having the pseudo-stratified ciliated columnar epithelium. Obviously with some exceptions like vocal cord and the upper border and the lingual surface of the epiglottis. Well, vocal cord and the lingual surface of epiglottis, they are subjected to a lot of friction. And we said whenever we say the friction, the lining epithelium has to be the stratified squamous epithelium. So this is the epithelium of this respiratory tract till the proximal bronchiole. Remember these exceptions there, the vocal cord, the true vocal cord, and also the upper border and the anterior surface of epiglottis, also called as the lingual surface, also called as the oral surface of the epiglottis, where we have stratified squamous epithelium. So as we already said, in the large bronchiole, the lining, or you can say the proximal bronchiole, the lining epithelium is just like the trachea and the bronchus, which is pseudo-stratified ciliated columnar epithelium. But when you come to the terminal bronchiole is again having the ciliated cells, but these are the ciliated columnar cells. Rather than pseudo-stratified, we have a ciliated columnar. And more you go into the distal part, it becomes ciliated cuboidal type. So if the question is asked, the better answer is this ciliated cuboidal cell, which are seen in case of the small bronchiole. With no goblet cells. The goblet cells are now replaced by the Clara cells. Now, what are Clara cells, guys? That is again is an important cell to be remembered. The Clara cells are doing the same function which is done by the type 2 pneumocytes in the alveolus, and that is releasing the surfactants. Clara cells, as you can appreciate in this picture, are those cells which are not having the cilia. These are the non-ciliated cells. And if you look at the apical surface of these cells, they are present like a dome. That's how we identify them. Because when you look at the usual ciliated columnar epithelium, you can see those ciliations over there, and their surface looks flat. But in case of these, the cells where you can see these arrows pointing, these are the non-ciliated cells, and they have the apical surface which is more like a dome shaped. And as I already said, what they're doing, they are secreting the surfactant, and that surfactant is keeping the distal part of this airway patent. It is preventing the collapsing of the distal airway. See, in the proximal part of the airway, we got the cartilages. We got the hyaline cartilage present in the trachea and the large bronchus. And anyways, the size of those, the proximal part of the respiratory passage is huge, and the diameter is large. So it's not easy for it to get collapsed. But when you go into the distal part, the lumen gets very narrow, and we need to have some compensation there. I mean, we do not have a cartilage there, but we need something else, and that is the surfactant which is released by the Clara cells, which is very, very important. They're forming the small population of cell in the terminal bronchiole, and they will keep on increasing when we go toward the respiratory bronchiole. So as we said, the next here is the respiratory bronchiole. The respiratory bronchioles are the one which are having the lining epithelium, which is indicative of the same terminal bronchiole. But see, that will gradually change. Terminal bronchiole is having ciliated cuboidal epithelium. So a respiratory bronchiole now will have a function. It is the first part of the lung basically where you will see the gases exchange taking place. So the function of cilia is now getting over. All those keeping the impurity out and just, you know, the beating of the cilia to flow the mucus along the lining, that part is done. Now the gases exchange has to take place. So the lining epithelium in the respiratory bronchiole will be seen varying from the simple cuboidal epithelium, from the ciliated cuboidal epithelium to the simple cuboidal epithelium. So they will lose their cilia in the distal part. The Clara cell will increase in the distal part of the respiratory bronchiole because more surfactant is required to be released in that region. So that is the lining epithelium of the large bronchiole, which is just like the large bronchus or the trachea. Small bronchioles which are having the lining epithelium of the ciliated cuboidal rather than pseudo-stratified, but the goblet cells are replaced by the Clara cells which release surfactants, and we identify them based on the dome. And then respiratory bronchiole. But I tell you, if the question is asked on the respiratory bronchiole, and let's say if you get both these options to choose from, that whether they are ciliated or non-ciliated, go with non-ciliated. The non-ciliated cuboidal epithelium, because as the name suggests, respiratory epithelium. So we need to answer the question based on the function, that is respiratory, that is the gases exchange. And that cannot be done by the ciliated cuboidal, that is done by the non-ciliated cuboidal epithelium. So finally, moving on to the alveoli is which is having the two types of cell present. We got the type 1 and the type 2 pneumocytes. We call the type 1 and type 2 pneumocytes. The type 1 pneumocytes, these are the predominant cells which is covering the surface of the alveolus, and they are the one which are taking part in the gases exchange. So the 95% of the cell population inside the alveolus, that is by the type 1 pneumocytes only. And these cells are like the usual flat cells that you see, that is the type 1. Type 2 pneumocytes, which are the mimic cells of the Clara cells, and these type 2 pneumocytes are more of a cuboidal cells, but with a microvilli. If you look at in the picture, they are covering the 5%, the remaining 5% area of the alveolus, and these are the cuboidal cells, but we have a microvilli on their surface. Look at that, and we know that they are also secreting the surfactants. So that's the type 1 and the type 2 pneumocyte that you will see in the alveolus. Now let me show you one real-time section for that. I hope you can easily appreciate the difference between the type 1 and type 2. The type 1, look at these flat cells over there, and type 2 pneumocyte, as you can see, this huge cell, the cell with a big rounded nucleus, and when you say the rounded nucleus, it is indicative of the cuboidal type of the cells which is present. So this is about the lining epithelium of the respiratory tract. So let us finally summarize the lining epithelium of the respiratory system. As we said, starting from the nasal mucosa and all the way till the proximal part of the bronchiole, the large bronchiole, we have the same epithelium, that is the pseudo-stratified ciliated columnar epithelium. In case of terminal bronchiole, we said those epithelium, they do not have a goblet cell, and the lining epithelium is more of a cuboidal. It's a ciliated cuboidal epithelium with no goblet cell. The goblet cells are replaced by the Clara cells. Respiratory bronchiole, the lining epithelium again now changed from the ciliated cuboidal to the simple cuboidal. And I said if you have to go with one, go with the non-ciliated cuboidal epithelium in that case. And finally the alveolus, which is having the type 1 and type 2 pneumocytes. And because the predominant cells are the type 1 pneumocytes, so if you have to go with one option, that obviously is a simple squamous epithelium. So that's about the summary of the respiratory system lining epithelium. So guys, in this section, let's talk about the lining epithelium of the urinary tract. Now you're looking at the picture of the nephron. So in this, let us talk about the lining epithelium of the Bowman's capsule, PCT and the DCT first. Now the lining epithelium of the parietal layer of the Bowman's capsule is the simple squamous epithelium. As you can see in this picture here. Now this is the parietal layer of the Bowman's capsule, and the lining epithelium here is a simple squamous epithelium. Whereas in case of the PCT and DCT, the lining epithelium at both the side is the simple cuboidal epithelium, but the difference will be in case of the proximal convoluted tubule, the lining epithelium is simple cuboidal but with a brush border, and that makes the lumen of the PCT a bit hazy. Whereas in case of the distal convoluted tubule, the lining epithelium is again simple cuboidal epithelium, but there is no brush border. Now, as you can appreciate in this picture, if you look at the section where the PCT and DCT are marked, the diameter of the proximal convoluted tubule is way more than the DCT. The PCT are approximately, they are on average like 60 to 70 micrometer in diameter. Whereas when you compare it with the DCT, which is hardly 15 to 20 micrometer in diameter. So there is a huge difference between the size, the diameter of the PCT and DCT. But because PCT epithelium is cuboidal with a brush border, and that brush border will make the lumen very hazy. Can you all see all these lumen inside are very hazy? But look at the DCT. Again, the lining epithelium is what? It is the cuboidal only, but we do not have the brush border. So the lumen looks clean, the lumen looks larger in size as compared to the PCT. Now in this slide, let's talk about the lining epithelium of the loop of Henle. Now, first of all, we can see the loop of Henle can be divided into this thick descending limb. Then we have a thin descending limb. Then we have the thin ascending limb, and we have a thick ascending limb. So that's the loop of Henle. So first let's look at the lining epithelium of the thick descending limb and the thick ascending limb. The good thing is thick descending limb is close to PCT and thick ascending limb is close to DCT. So their lining epithelium is exact corresponding to the same only. So the thick descending limb of loop of Henle, if the question is asked, the lining epithelium is just like PCT, which is a simple cuboidal epithelium with a brush border. Whereas the thick ascending limb close to the DCT, so the lining epithelium is same as of DCT, which is a simple cuboidal epithelium which is devoid of the brush border. Whereas when you talk about the thin segment, that is the loop of Henle, the thin segment of the loop of Henle, See, the diameter of the loop of Henle is approximately 15 micrometer, which is the same diameter for the venule. So when you look at the section of the histological section of the kidney, there are good chances of confusing the loop of Henle with the venule which are present around. If you look at the stains of the RBC inside, that could be helpful. But if let's say there are no RBCs to be seen inside the venule, they look more or less like the venule only. So the loop of Henle, the lining epithelium, just like venule, is also having a simple squamous epithelium with some microvilli present in that. We have a simple squamous epithelium. And look at this picture. If you look at this picture, now these are the venules and these are the loop of Henle. So they look, if you look at the wall, they look more or less the same only, because they both are having the single layer of the squamous cells which are encircling the inside, or they're lining them. So the loop of Henle, the thin loop of Henle, if the question is asked, the lining epithelium is simple squamous with microvilli. Thick descending limb, simple cuboidal with brush border. Thick ascending limb, we have the cuboidal epithelium with no brush border in that case. And then talking about the collecting ducts, guys. The collecting ducts, if you look at the lining epithelium of collecting duct, that is again an indicative of the lining epithelium of the portion which is just proximal to it. That is DCT. DCT was having a simple cuboidal epithelium, and so the collecting duct will be. But the way we'll differentiate the lining epithelium of the collecting duct from the DCT is by looking at the sharp and the defined margins of those cuboidal cells, which is not seen in case of the distal or the proximal convolute tubule. Now you can see this is one section, a wonderful section from the collecting duct. And if you look at these cuboidal cells, you can see a very, very clear margin of these cuboidal cells, which is certainly not seen in this section. This is one PCT you're looking at here nearby. And look at all these hazy lumen inside, and even the cuboidal cells which you can identify based on the nuclei, but the margin between the cell is not clear, which is very clear in case of the collecting duct. So let's say if you get a section, histological section of the kidney, and you have a confusion between whether you're looking at the DCT or a collecting duct, because both are having the same type of epithelium, make sure you look at that which of them is having the clear cell margin, and that will help you identify that which one is a collecting duct. Also, collecting duct in the most distal part, like close to the pyramid of the kidney, those are called as duct of Bellini. And those duct of Bellini, the lining epithelium, is the same epithelium that we have here, that is a cuboidal epithelium. So duct of Bellini, which is the most distal part of the collecting duct, which is close to the, or you can say near to the apex of the pyramid, the lining epithelium is same, that is the cuboidal epithelium. Now the rest of the urinary tract passage, which consists of this minor calyx, the major calyx, the renal papillae, then we have this ureter, the urinary bladder, and even the proximal part of the urethra, that is the prostatic urethra. And then we have this membranous urethra, penile urethra, and then the terminal urethra. So starting all the way from the minor calyx till the proximal urethra, or you can say the prostatic urethra, all this portion is having the lining epithelium, which is a typical lining epithelium of the urinary tract, that is a transitional epithelium or the urothelium. So this portion is having a transitional epithelium or urothelium. We already discussed the transitional epithelium, which is having the top layer made up of these umbrella shaped cells or the dome shaped cells, which may be binucleated at some certain places. Then starting from this membranous urethra, the membranous urethra and this penile urethra, the lining epithelium is more indicative of the lining epithelium of the genital tract. And that lining epithelium is pseudo-stratified ciliated columnar epithelium. So guys, the membranous urethra and the penile urethra, the lining epithelium is pseudo-stratified ciliated columnar epithelium, which, as I said, because the ejaculatory ducts are opening in, so beyond that the lining epithelium is more indicative of the lining epithelium of the genital system rather than the urinary epithelium. And then finally the terminal urethra. When every time you talk about anything terminal, the terminal part of anal canal, the terminal urethra, the lining epithelium is again what? That is the squamous epithelium. So it's the stratified squamous epithelium which is seen in case of the terminal urethra. So that is the lining epithelium of the urinary tract. And finally, let's conclude this part by looking at the summary of the lining epithelium of the urinary tract as well. So starting again with the Bowman's capsule, we said the parietal layer was having the simple squamous epithelium. Then we have the PCT and the thick descending limb, which was having the same epithelium of the simple cuboidal epithelium with a brush border. The loop of Henle, the thin part, that was having a simple squamous epithelium, which we said we need to differentiate them with the venule, the simple squamous epithelium with the microvilli. We have the thick ascending, thick ascending limb and the DCT, and also the collecting duct. Again, they have the same kind of epithelium, that is the cuboidal epithelium, but this time it is not brush border. Although in the collecting duct, you may have a columnar epithelium at places, but usually it is cuboidal only. Then moving on from the minor calyx till the prostatic urethra, it is all transitional epithelium. Everything in between, it is having all transitional epithelium. Membranous and spongy urethra is pseudo-stratified ciliated columnar. And finally, the terminal urethra is having the stratified squamous epithelium. So this is about the important lining epithelium of the three major system. I hope you find these videos helpful, and if you do, make sure you leave the comment after the video. Thank you.